So I assigned myself this topic of neuropathy just because I always like to learn more stuff. So I'm trying to go through and think about what this means to chronic pain and what this means in the patients that we can look at, or people who have their own issues, and trying to figure out where to go with all that. So pain and EDS, of course, this is a common problem, but I think one of the things that that practitioners, we all realize that it's not just musculoskeletal pain, it's not just nociceptive pain in terms of ongoing joint trauma. The patients with EDS seem to have neuropathic pain also, and by that I mean burning, pressing, paroxysmal pain, which just means a burst of pain, evoked pain, so something is done and you get pain for then not necessarily musculoskeletal, and then paresthesias or dysesthesias. So what this dysfunction of the nervous system is not entirely clear, and hopefully something that can be figured out over time. So there's a questionnaire that looked at pain in EDS, and of course it was chronic pain is highly prevalent. Pain is more prevalent and severe than you would expect from, because the EDS hypermobility type says, oh, that's just a, musculoskeletal problem. And so the answer is the pain is much more severe. And then it is related to having hypermobility and dislocations in past surgeries, but it's also related to sleep disturbance, and it certainly impairs people's day-to-day life. So I'm going to go over the treatment for neuropathic pain first, because it kind of applies to all the things that I'm going to talk about later. And this is by no means an extensive list, because everybody is coming up with new things to try. I heard about somebody talking about using Xyrem or Rohypnol for pain. I don't know if that's because it makes you sleep or there's really something else to it. So over-the-counter analgesics, ibuprofen, naproxen, acetaminophen. I think a lot of people kind of diss acetaminophen, and it does help some, and sometimes it's co-effective if you're taking something else. Tramadol is certainly one of the common opioids that is used, and oxycodone, morphine, Dilaudid, all those things are something you want to use, but overall you want to use opioids short-term and sparingly, because you can get in trouble when because it primarily causes problems in your GI tract. Sometimes a burst of corticosteroids is helpful. So antidepressants, kind of the tried and true, amitriptyline and doxepin. I don't use that for headaches, but it does seem to work for this kind of pain better than the other tricyclics. And I think the newer medicines, Cymbalta and Savella, the serotonin norepinephrine reuptake inhibitors, I think are really helpful because they do a lot of different things. They're helpful for chronic pain, and they also have an anxiolytic trait quality to it. So as all of us know, some of the kids and people with EDS have horrific anxiety, and that always makes pain much more difficult to control. So anticonvulsants, gabapentin and pregabalin are kind of the big ones. Carbamazepine is an old one, but sometimes you kind of come back to the old guys, and you get some help there. Lamotrigine is also helpful. So it's interesting, the carbamazepine and lamotrigine are sodium channel anticonvulsants, and so where does that play into neuropathic kind of stuff? So the NMDA antagonists or dextromethorphan, I've not ever had a huge amount of luck with that. Anybody taken that and had it work or know about that being working? I know people always put it in the list, and I'm just like, okay. But ketamine is certainly very helpful, either getting a prolonged infusion or being in the hospital and getting started on it, and then taking it as an outpatient. The few patients that I have on ketamine, I get phone calls from the ER, like, what are you doing? So all the time. So I get those all the time anyway. So intravenous lidocaine, low dose naltrexone, which is something that Dr. Chopra puts forth and has a lot of success with. But the other things that I think that don't get used as much as they can, because everybody thinks you take a pill and everybody gets better, and that is that you have to use non-pharmacological management other than the topical agents. But so cognitive behavioral therapy, you know, some people have difficulties hearing that you need a mental health care provider helping me take care of you. And it was, I'm not crazy. I said, I didn't say that. You have chronic problems, and it's hard to be chronically ill. And so you have to, and on some level, there isn't a magic pill. And so you have to learn how to work through that. Now, the trick is trying to find somebody to help you do that, because that's the problem. We have a new psychiatrist that I'm begging her to do outpatient stuff, but right now she's mostly inpatient. So, but it's hard to find people to help you with that, because especially in EDS, you are going to have chronic pain. So you do need to learn how to work through it. You know, people say, I have severe pain, and I said, what's your regular pain like? A 5. So they live with moderate pain all the time, wherever it's coming from. If it's coming from musculoskeletal stuff or coming from neuropathy, which I think is part of what's going on. I find TENS units helpful in some people. Acupuncture is helpful in some people. I teach my headache patients how to do acupressure, but that's a little easier to do. The big one, and as I was just talking about, is restorative sleep. You know, there's two problems there. One, just because your eyes are closed doesn't mean you're getting restorative sleep, and I think that's the biggest, problem. And two, you're so fatigued during the day, you sleep during the day, and it messes up your sleep at night. And actually, 3, the medicines we have people on mess up your sleep sometimes, and so you go round and round. But as I tell my patients, sleep is magic. So we have to get you to sleep. You have to get good sleep. So the type of neuropathic injury in EDS. So I do think kids get stretch injury and compression injuries. So it's interesting as a neuromuscular doc to go back and look at the literature about neuropathy in EDS, because most of the time they're talking about what I would call a mononeuropathy. They sometimes label it as a polyneuropathy, which means a generalized neuropathy. But what they're looking at is mononeuropathies, or plexus injuries. So you get a stretch in your brachial plexus, you get a stretch in your lumbosacral plexus, so shoulder and hip, or individual places that can be looked at. I think there's a peripheral neuropathy component to EDS. I don't understand it yet. Hopefully I will one day. But I see kids as a neuromuscular doc who have a very typical neuropathic pattern. So what happens in a neuropathy, most of them are length dependent, meaning the legs get affected before the arms. So they start getting hammer toes, they start getting pes cavus, and then they start getting weakness in their lower leg, which is a very, very typical pattern for neuropathy. So I work them up for stuff and I can't find anything, but I think it goes back to, certainly in some patients who have more systemic illness, there's another underlying problem besides the joint hypermobility. I think the joint hypermobility, we call it EDS hypermobility type, but whatever that other underlying process is to be determined, I think, and in some patients you find the magic combo, but in others, it's still looking. So in complex regional pain syndrome, I think it could be related to recurrent stretch injury, because people say, well, I didn't do anything to hurt myself. But of course, patients with joint hypermobility, they're hurting themselves all the time, and not really, because they deal with it and they live with it, so they don't realize that's what's going on. And then tethered cord, I think, comes into this because, and you'll hear a little bit more, I'm assuming, about that from Dr. Henderson. Okay, great. I'm going to talk a little bit about it. So, there's case reports. So patients with brachial and lumbosacral plexus injuries, some of them have recurrent episodes of weakness. One pretty good paper, but I didn't agree with their conclusion, but one pretty good paper looked at ulnar neuropathy, because that's an easy one to look at, because your ulnar nerve will roll in and out of this little groove that it's supposed to sit in. So they get a lot of subluxation and luxation, so out and in of the ulnar nerve. It does not correlate with EMG, and I think there's a good reason for that. When you look at sensory fibers, there's two kinds. There's kinds that are covered with myelin, and there are kinds that are not covered with myelin. And myelin is kind of a fat that protects the nerves in the big picture. The ones that are small fiber, not covered with myelin, it's pain, temperature, light touch, and nerve conduction studies don't look at that well. You have to have a pretty bad neuropathy before you get some idea about that. And pain is a symptom of a small fiber neuropathy. So people go, well, your EMG is normal. Yeah, you don't have a neuropathy. That's not true. You don't have a large fiber neuropathy, or your neuropathy is not bad enough yet. So, large fiber is vibration and proprioception. I don't see that in patients. They don't, even if they do look like they have a neuropathy, they don't lose their position sense or vibration. So trying to fit all this under one umbrella, you can't, because I end up kind of looking piecemeal, trying to make a big picture. So the patients who have small fiber peripheral neuropathies, and these are mostly patients who present with chronic neuropathic pain. By the by, most of them have dysautonomia. Well, this is a small fiber neuropathy. Where's the dysautonomia coming from? And 90% cardiovascular, and 82% gastrointestinal, and 34% urological. That one always bothers me, though, because is that tethered cord? I mean, I'm not sure about that one. I feel a little uncomfortable saying that's autonomic. But they also have chronic headache and chronic fatigue. How about that? Where does that come from? From a small fiber neuropathy. That doesn't make much sense pathophysiological to me, but maybe I just haven't thought about it right yet. So if I'm looking at somebody with an axonal neuropathy, meaning small fiber, you always have to look for treatable causes. And you have to make sure that just because we have a label for the big picture doesn't mean you don't have another problem. This doesn't come up under the neuropathy picture, but certainly a lot of folks have vitamin D deficiency. One, we don't go outside, and two, when we go outside, we wear sunscreen. So a lot of us get vitamin D deficiency, and some worse than others. But hemoglobin A1C for diabetes, B12, vitamin E, B6. So people think more is better, and in vitamin B6, more is not better. If you take more than 200 milligrams a day of that, which is not in the regular B complex, but some people go buy individual ones, it can actually give you a neuropathy. And I've found several people who do that, and they don't, when I ask them what medicines they're taking, they don't necessarily tell me. And then when I check that and it's over the upper therapeutic level, it's like, you take B6? Oh yeah. Yeah, I take 1,200 milligrams a day, and I'm just like, stop. So ANA and Cedrate, looking for more kind of inflammatory stuff. I mean, these are just screening labs, and if the screening labs are negative, does it mean you don't have a vasculitis? No, but and serum protein electrophoresis, which I don't see much in kids, but that's always on the list for neuropathy. So I said nerve conduction studies, and I think that's still part of what you do, but I think the bigger thing is doing punch biopsies. So here. So this is nerve conduction studies where you put little electrodes on, and they don't show the stimulator here because they don't want to show the bad part. Then you take a stimulator and shock over the nerve and watch the response over the nerve. Punch biopsies, you take what looks like a hole puncher and you push it into the skin and you twist and you pull out a plug. It makes, everybody's cringing. Like, You put lidocaine first so it doesn't hurt. It does leave a tiny scar. My problem as a pediatric doc is that they don't have any norms for kids. So unless somebody just has complete absence of small fibers, I can't tell. They dance around and go, well, we don't have controls, and if this were an adult, it might be abnormal. So I'm just having to wait for people to get controls for the punch biopsies, because I think folks with chronic pain, this needs to be looked at more. And I know Aurora has talked to me about a neuropathy person at Mass General, and I tried to reach her, but I couldn't get her. So, because there is somebody who's looking at it, and it's interesting, she was involved in an article in like 2006 that looked at EDS and small fiber neuropathy, then she quit looking at it. So I don't know if she's secretly looking at it and she's going to tell us soon, but it's not in the literature. So whatever she's learning from that, she hasn't let go of yet. So treating axonal neuropathy, so treat the underlying etiology. So if I can find something, then obviously you treat that. There's a lot of discussion nowadays about axonal neuropathies or small fiber neuropathies being inflammatory. So an inflammation always comes up in the discussion of EDS, and where does that play into the picture? So a lot of people with chronic pain are getting intravenous immunoglobulins, and their chronic pain is getting better because they have an inflammatory neuropathy that you can't necessarily prove, and I certainly can't prove in my patients. But it's hard to get because it's very expensive. But sometimes, I mean, I've had one patient that I've begged for over a year, and we just gotten started, so I hope it works. But then just treatment directed to the regular neuropathology, as we talked about before up front. So when you're thinking about tethered cord, these are kind of the big things that you think about. Bowel and bladder dysfunction, back pain, leg pain. So I just recently had a patient who was telling me about her bladder symptoms, and she had chronic pain, but she always talked to me about her hands, and so I was just like, I don't get it. So then she says, oh, by the way, I've had bowel incontinence for years, and I'm just like, so she's getting her MRI is normal, but she does have a tethered cord. But back pain and leg pain are kind of the big ones for tethered cord. So I found it interesting, talking about treatment, tethered cord, conservative treatment, and that's true. I mean, if you don't want to do surgery on somebody who you could treat otherwise. I think the fourth thing of follow closely, because once you get bladder dysfunction from a tethered cord, then you're kind of, the horse is already out the barn down the road. So because that may not get better, and then surgery. So complex regional pain syndrome, Dr. Chopra could talk about that all day. So I'm just going to kind of talk about some of the things. But why do people who have ADS particularly get complex regional pain syndrome? Because they have recurrent stretch injuries with joint dislocation or hyperextension. I mean, so they have chronic injury, not an acute injury. Everybody says, well, you hurt yourself, you get CRPS. Well, you have chronic hurt yourself, get CRPS. And then, by the by, you get a lot of surgeries, and then you get CRPS. And so you get into a bad spot because you need the surgery because your joint won't stay in, your bones won't stay in the joint, and then you have problems afterwards. So treatment of chronic regional pain syndrome. This in particular, I think, has been looked more closely in terms of pain management. And the top thing is probably the most important, and again, this is because it's a chronic pain syndrome. And fortunately, there are now more and more day programs where people come in and get PT and OT and psychological therapy for 3 or 4 weeks at a time, just trying to help them kind of regroup and figure out what to do and work on their therapy and try to figure out and help to get better. Short-term use is opioids and corticosteroids and chronic medications, as we talked about earlier. So this is one of the things that I wanted to talk about. So somebody who has acquired pes cavus, how do I, as a neurologist, neuromuscular person, think through that? So is this neuropathic? Do you have an acquired neuropathy? Is this tethered cord, or is this chronic regional pain syndrome? So go back to the concept of chronic regional pain syndrome. You don't have a big injury in the classic type. You have a chronic, indolent, underlying injury. So you may have, when you get down to your fifth person looking at you for that, you have a pes cavus because of your neuropathy and your contractures and your muscle wasting. So you can see people with acquired pes cavus, and if you don't go back and say, was your foot ever swollen? Was your foot ever red? You know, did you have temperature problems? I think it gets to be something that could be missed. So this is what a pes cavus looks like. Just the high arch and the hammer toes. So, you know, this is a normal foot and this is a cavus foot. So, I mean, why do you get a cavus foot? Because you're getting them from weakness. So you're having muscle weakness in your feet, and that's why you develop a cavus foot in terms of acquired pes cavus, because you can certainly have congenital for other reasons. So for axonal neuropathy, hammer toes, pes cavus, foot drop. So that's the first real sign of weakness that the patient will appreciate. They don't really, even if they have hammer toes, they don't know that the muscles innervating their toes are weak. But when they start having a foot drop, then they go, there's something wrong with me and I'm having problems walking. So they already have gait problems and now they have a new problem and it's hard to separate out. As a neuromuscular doc, it's always funny, I hear somebody coming down the hall with this flap, 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 flap. So I turn around to see who they are. And a lot of times, actually, unfortunately, it's the leukemia patients because some of their medicines give them a neuropathy. But going back to this, and going back to the axonal neuropathy, they lose their ankle reflexes. So that's one of the key things in terms of trying to think about what is going on in acquired pes cavus. So as I mentioned a little bit, but the skin changes and the color changes and the temperature changes, you know, those may be indolent, happened so long ago people forgot to think about them. They clearly get muscle hypertrophy, you know, wasting of their muscles, and that leads to fixed contractures, which looks like a pes cavus. And they will have normal reflexes until their weakness is so bad that they lose the reflex. I mean, reflexes, you hit the tendon, it goes up to the spinal cord, it comes back down and activates the muscle. So you have to have a lot of disuse before you lose the reflexes. And sometimes people have such bad fixed contractures of their ankle, you can't check their reflexes. Yep, sorry, what did I do? Oh, sorry, tethered cord. So they can have hammer toes and pes cavus. And I think a lot of times that's apparent, again, because it's not symptomatically a problem, but somebody comes to somebody with back pain and they don't look at their feet and they don't realize that they've already acquired a pes cavus, and that's because they have a tethered cord. These kids have increased reflexes, and that's, I think, the big key in terms of examining people. And I don't know, I think all neurologists are a little off. So I get really mad that they have the little tiny little hammer that I hate. It's like, well, why don't you get a real hammer and then you might get real reflexes. So a lot of times I think, you know, people say, well, they're normal. I mean, the rehab doctors, and bless their hearts, they check it with their fingers or their stethoscope. So I just like, y'all are hurting me. So, and they get what's you know, classically called a Babinski, when they scratch the bottom of your feet, we're looking to see if the toe goes up and down, up or down. So, red feet. You know, so you get, obviously you have the nail changes in the one on the right in terms of chronic regional pain syndrome. This is a small fiber neuropathy, and this and this need to be treated differently. So you come in, and you can have, of course, bilateral complex regional pain syndrome, even at presentation. So not all red feet is chronic regional pain syndrome. Sometimes you can have erythromelalgia in it. And they are very similar, and as I think back to my own practice, I've probably not gotten it on a couple of patients because I didn't get the erythromelalgia stuff because it's not very common, but it's probably more common than people realize. These are the kind of things you see in patients with tethered cord. If you don't look at the patient correctly, you're not going to realize that one foot is smaller than the other. So even though the tethered cord is a midline problem, you often see asymmetry in the lower extremities. Clinically, the way you ask about that is, do you have problems buying shoes because your feet are different sizes? I mean, everybody has a little. But, you know, well, I have to buy 2 pairs of shoes because they wear a 7 on this and a 5.5 on this. Well, that one's pretty clear. And if you look at them from behind, sometimes it's easier to see the muscle wasting. You know, and this kid obviously has some ankle weakness because he's has deformity there. So evaluation of tethered cord. I've been looking at lumbosacral spines, prone and supine, because you lie on your back and then you put them forward. Sometimes you can see movement forward with the tethered cord. In EDS, of course, that doesn't mean they don't have tethered cord. And just because you have a normal test doesn't mean you don't have a problem. And then urology consults. And again, the bladder is very helpful in trying to figure out what's going on. I mean, from my end, increased reflexes and bladder dysfunction is tethered cord until proven otherwise. So at VCU, we've had like 9 patients with occult tethered cord, and those are the symptoms they had. Not all of them had urodynamic problems, but it's hard to convince some neurosurgeons, and bless Dr. Henderson, some neurosurgeons to do surgery, because there's always the phrase for surgery is to cut is to cure, but they always remember their other phrase, with to cut is to cry. So you don't want to hurt somebody if they don't need surgery. So when you're looking at chronic regional pain syndrome, I have a hard time finding kids' feet in Google images. This is kind of the typical, you know, CRPS thing. It's like, you don't have this, you don't have CRPS. This person, you know, you would think they just have poor foot hygiene and maybe they have diabetes, but they have pes cavus, and this is the kind of thing that you see in a kind of a chronic picture. And there are criteria for chronic regional pain syndrome. So you must have some of the sensory, and you have to have these either now or in the past, and there's nothing else. And again, you have to go back and look and see what else could cause that. And in my mind, you have to look for erythromelalgia. Some of that is genetic, so you have to ask about family history. So anybody in your family had red feet, because it can be genetic. And you have to look, make sure you don't have another reason. I tell you, it's hard to do nerve conduction studies on people without procedural sedation when they have RSD, or complex regional pain syndrome. So I'm going to switch gears a little bit again, because I kind of have little pieces here, but I always, certainly part of what a lot of us do is think about the dysautonomia in Ehlers-Danlos. So why do they have dysautonomia? I think there's an underlying neuropathy going on there, a polyneuropathy, not just individual nerves. Whether or not it's the connective tissue laxity, whether or not the medications we're giving them to try to fix something else is making the dysautonomia worse. But I think some of it is sympathetic dysregulation, where they have resting sympathetic overactivity, and I'm sure Dr. Niche will help us a little bit thinking through that, and then decreased sympathetic reactivity to stimuli, and Dr. Rowe also. And everybody has their own way of thinking through it, and which is what the cool thing about this conference, because we all learn from each other. So, you know, the vessels in patients with EDS have increased distensibility and allow for venous pooling, and orthostatic intolerance correlates with the Beighton score. Things that can help you have dysautonomia in terms of making problems worse. Opiates are a problem, trazodone's a problem, which I use a lot of for sleep, and you have to be thoughtful about it. beta blockers and tricyclic antidepressants can all confound the problem in terms of dysautonomia. So there are some tests to look at in terms of, do you have dysautonomia? Most of them relate to measuring your heart rate, measuring your blood pressure, being on a tilt table, but there also is this test called QSART that, amazing but true, is a small fiber neuropathy. So, and amazing but true, oops, some of those patients also have dysautonomia. So I always like reading articles where they have an abnormal QSART, and by the way, they have dysautonomia. and I think the next step is people don't look for Ehlers-Danlos. They don't look for joint hypermobility, and so whatever you don't look for, you're never going to see. And thanks to TCAP and for all you guys that teach me, I appreciate it.